Good afternoon, everyone, or good morning. This is Todd Montigney from the new SimiTree Healthcare Consulting. And today I have Maureen Kelleher with me. And just to kind of go through some basics on our webinar today on the palliative care program, managing finances for a successful program. You probably heard early last week, an announcement went out that Blacktree Healthcare Consulting, who historically did these webinars to the crew that's joining today, merged forces with Simeon Healthcare Consulting to form SimiTree Healthcare Consulting. So we are a full-service consulting company servicing the post-acute and really bringing the best of both worlds together to really benefit the post-acute industry, specifically with service offerings and expertise that we feel is unmatched across the industry. So if you have questions about that as we move forward, we'd love to hear from you. We have contact information at the end of this presentation for Maureen, and we also you can reach out to the SimiTree or through our past contact information and also some additional contact information that we can provide at the end. So with that, we'll jump right into this presentation. We did a similar presentation a few months ago on palliative care. It was very well received, and there was a lot of great questions that came from it. So this is kind of an add-on to that, really talking about the finances and the success and how to make it a successful program. And Maureen, who did our last presentation, just a little bit about her is she's an RN. She's been in the industry for over 24 years, with 19 of those years really focused on hospice and palliative care. And I'll say, I've worked with Maureen for the last, year and a half. She's very passionate about palliative care. She really believes in the program. She believes in hospice as well. She believes in the mission of serving patients, and we're very excited to have her as part of the SimiTree team. But with her background in those 24 years of healthcare experience, she worked in a family practice administrator. She was in the hospice nursing, palliative care, and multiple hospice executive positions throughout the United States. So we're very excited that she's here today. We're very excited to have her present on palliative care again. I'll get a little bit more down into the weeds than we did last time we talked about forming a program. And from there, the format of today's presentation is going to be mostly her presenting. We're going to have some slides that pop up and some questions. I think there's about 4 questions we have, or poll questions for you that we'll ask you to answer. So I'll interject myself during those poll questions. I'll be monitoring the Q&A as well. So if you have any questions, type them in. I'll be trying to either answer them throughout the presentation, or we'll save them towards the end where Maureen can answer them as well. So with that, I'll turn it over to Maureen. I'll let her go through the agenda and we'll go from there.
Thank you, Todd. Hello, everybody, and good morning or good afternoon, depending on where you are in the country. Today, we're planning on going through palliative care basics, funding for palliative care, Medicare billing and coding, insurance contracts, managing expenses, and defining success in palliative care. And we do have a first poll right here.
And I'll read this, Maureen, and we hear a lot about profitability of palliative care programs. And we talk with a lot of our clients. They say, we think of this as a loss leader. So we just want to get some feedback from all of you. Is if you have a palliative care program right now, are you profitable? If so, there's a couple of ranges there. If you're not profitable, there's a couple of ranges there. And the last bullet, or the last checkbox, is we haven't started a palliative care program yet. So if you want to just take a moment, answer that question, and we'll share some results with you throughout the presentation.
Okay. All right, I'm just watching the polls number. It looks like a good number of people on here have not even started a palliative care program. So this is going to hopefully be good information to get your feet on the ground running. The basics of palliative care, just defining a community-based palliative care, because we already know there are multiple hospitals that have inpatient palliative care, and it seems to be the program that was most widely started. Community-based palliative care is defined by the Center for the Advancement of Palliative Care as a specialty palliative care for seriously ill patients and their families, provided in a range of venues. So this can be done in a patient's home, it can be done in assisted living, it can be done in a facility, skilled nursing facilities, long-term acute care, group homes, or homeless shelters. So it really is taking the provider out to the patient wherever the patient is. Some basics on what return on investment is. There are now fee-for-service payments. There's per member per month payments, and there are grant options, and there are some nonprofit programs that use donations to help fund their palliative care programs. There are actually some palliative care programs out there that are showing up to 5 to 10% profit margin. Typically, they're seeing that once they're established and have a strategy for growing their program. The soft return on investment is what you usually hear about. It's increasing levels of care for patients. It's that safety net to catch patients in between transitional care, between acute care and going back home and their specialists. It also is the decreasing healthcare costs for insurance companies, for Medicare. It also is the return on investment for the patients themselves, getting them onto end-of-life services or hospice services earlier in the disease trajectory, and transitioning them to hospice sooner so they can benefit from those services for a longer period of time. A lot of hospice programs now are seeing their length of stay dropping significantly, and we're seeing increases in patients dying within 7 to 10 days of coming on hospice services. So hospice has always worked to get patients on sooner, and palliative care can help that somewhat. Funding for palliative care. So there are insurance reimbursements. Medicare does pay for palliative care under the Part B plan. They reimburse providers for home visits only if they are medically necessary. So you still have to have a reason why the patient can't make it to the doctor's office. So, they're on chemotherapy, their immune system is compromised. The COVID pandemic has been one reason why people who are compromised due to disease processes should not be going out into doctors' offices, or their doctors were just doing telehealth visits. They weren't actually able to go in and see their patients, their doctors anyway. Documentation has to document whether the home visit is a one-time or an ongoing or a permanent need for the patient. It should also prove the patient is not physically capable of traveling to the office. You can base this on physical or mental, but not on financial or personal issues. Patients do not have to be homebound under the traditional home care, but they need to have a reason they can't get to the doctors. And again, it's whether it's a one-time or whether it's going to be an ongoing. There's also private insurance, HMOs, and managed care payers that will pay for palliative care. Because it is Part B, it doesn't fall under the same requirements as Part A coverage. So some pay for certain things. Others will pay for a little bit expanded under their chronic care benefits or their transitional care management. You have to know what the plans are in order to make that fruitful for your palliative care program. And then some very few long-term care policies may have some benefits, but it's policy specific, and these long-term care policies usually have a lot of documentation requirements in order to get reimbursed for these. Then you have to look at nonprofit versus for-profit. For-profit can raise money from private investors. Usually that means that equity or dividends go to the shareholders, and ultimately a return on investment financially is expected, more so than the soft return on investment. A nonprofit, on the other hand, can seek donations and grants from individuals. Those stakeholders are usually looking more for the social or soft return. How is that benefiting patients and family? How is that benefiting the community? So in order to get paid from any of the insurances, you have to usually enroll or credential with them. Medicare and Medicaid have an enrollment process. To enroll in Medicare, you first need to start with an NPI number. Now, the NPI number can be under your tax ID number for your current home health or hospice program, if that's the way you're going to go, or you can set up a separate entity for palliative care and get an NPI number for a different tax ID number. Applying online is typically the quickest method to do this. And then you get to fill out the lovely 855B form and it goes to whatever MAC is in your locality that covers Part B. And it is typically not the same MAC as your hospice or home health. There are a list of forms that go with the 855B to Medicare, and these I've included the 4 main ones. So there's a form saying you want to participate and enroll with Medicare. There's an electronic forms transfer form so that they can submit your payments. There are the 855I, which is the individual providers who are not already enrolled in Medicare to enroll, and then all of your providers, whether they already have an MPI number or not, will have to do a reassignment of payment so that your program can bill and get paid, and then you pay the provider who's going to be doing that care. Medicaid.
Yep, I think we're pausing there for a second, Maureen. Just
Okay.
to keep everyone engaged in the next polling question of has your palliative care program enrolled in Medicare Part B yet? And when the options we have there is yes, we're approved on billing. Yes, we're waiting for a response, because sometimes you send that paperwork in, it takes a little while to be processed. No, we're working on the forms, or not yet. So those are the questions. We'll give you some answers. I know the good portion last I saw on the poll was 60-some% were agencies on here today that haven't started the palliative care program. So we'll see what the numbers turn out here, but we'll keep on going from here and share the results of all the polls with you at the end.
Okay. All right. So once you have your Medicare Part B established, then the program can apply for your state Medicaid system. Each state, from what I have seen, has their own process for enrolling, and in some states they may have more than one Medicaid payer, especially if they have their own HMO Medicaid product. There may be, you will have to look at your Medicaid website for your state to see exactly what forms you need. And in some states, and so some programs are going to need to apply in multiple states. So if you are a regional or a national program and you're going to expand your palliative care program into several states, you will need to enroll in each state's Medicaid payer system individually. Private insurance, these third-party payers, Aetna, United Healthcare, Humana, the best, safest way is to credential yourself and get on their panels as an in-network provider. Many HMO programs and some of the Medicare Advantage programs, if you're not in network, either you will get a reduced payment from the insurer, the patient will have a bigger financial responsibility, or they won't pay for your services at all. And if the patient wants to use your services, they will have to pay themselves your fees. So you need to understand that each payer, what their process is to credential, if they're accepting new providers at all to be in network, and then the credentialing process that each one has. Now, there is a program through the Council for Affordable Quality Healthcare called CAQH, and your providers we can get all of their information into this online program, and then the insurance companies get access to that so that it speeds up the credentialing, but it's getting all that information into the CAQH website first, and then that will help speed up some of the credentialing process with some of these insurance companies. Now, there are some insurance companies that are not taking new providers, again, it depends on where you are and whether the insurer, such as United Healthcare, has their own hospice or palliative care program. So I know in, say, near Denver, Colorado, United Healthcare has an Optum palliative care program. So they're not necessarily looking for other programs to come on their panels. So it's a lot of legwork, a lot of calling, but you can find that there are some programs that are adding palliative care to their network. And as some of these Medicare models go forward with the serious illness, the primary care first, the chronic care management, all of those programs, they're going to have palliative care in their network system in order to provide that continuity of care from birth to death. So you just keep trying. They're out there. So then we're going to go into coding a little bit. I'm not going to go deeply into the codes, but just so that you have an understanding, especially if you're already doing hospice and home health, that your coding and the way you submit claims and even the claim form is going to be totally different from what you're doing in hospice and home health. So there is another poll question that we have. Who's performing your quality checks on your evaluation and management coding? This would be for you if you're already doing palliative care, you already have a program. Do you have somebody who's doing frequent or occasional reviews to make sure the codes on the claims match the documentation? All right, and
thanks for jumping in there, Maureen. I think I was supposed to handle that, and as soon as the poll question popped up, I couldn't hit the unmic. So thanks for jumping in.
Sure thing. Teamwork. So for evaluation and management codes, these are CPT or procedure codes, visit codes, and these are based on the complexity of the visit, the time you've spent, and the location of the services. Medicare pays typically 80% of the allowed amount, and then the patient is responsible for 20%. And when you are a Medicare enrolled provider, you are required to make every attempt to collect that 20%. And you also have to let patients know when they're coming on that it'll be just like if they were going to a specialist or primary care physician. The Medicare will only pay 80% and they will be responsible for the other 20%. This documentation must support the level of visit codes used on the claim, including the number of diagnoses assessed, the time spent on the actual face-to-face visit, time spent counseling the patient and family, and the plan. And the plan of care is also different than what we're used to in hospice and home health. The plan of care is, what did the provider do during that visit and what's going to be the next step. So it isn't the full care plan like hospice and home health, but in this, it's usually if you see a consultant note to a primary care doctor at the bottom, it'll say plan and it'll list the new medications and follow-up visit in 4 weeks and patient to do this, or if they're going to refer out to other people or refer to a clinical social worker, that would be in the plan. And that's part of the documentation that's in a system that is set up for Part B billing. Coding for home visits, and just so you understand, there's the locations. There are specific codes for visits in a patient's home. There are specific codes for visits in a facility, like a skilled nursing facility. There are also what they call domiciliary codes, and those are for group homes and independent living. It's a communal living environment. I'm going to just go through the home visit codes to make it easier, but there are codes for different locations. So new patient visit codes, the documentation must include in 3 components: a focused history, a focused exam, and straightforward medical decision making. And established patients is the same, but it's more problem focused, because now you know, once you have that initial visit, you know what the symptoms are you're going to be managing, and it's more focused on the reason you're there for the visit. That first visit is to get all the information, to develop your plan and the goals of care for the patient. And then this one is more focused on the specific problems as you go forward. And those problems can change, but your claims and your documentation are going to be more problem focused once they're established patients. These are the codes for the home setting. The new patient codes, there are 5 of them, and they go from just a basic 1 diagnosis, 20 minutes face-to-face with the patient or family, not a whole lot of decision making. You don't typically see this code for a new patient coming into palliative care. You would normally see some of the higher complexity codes being used. And then I go through, it comes with how many diagnosis systems and how many minutes are associated to that code. And I know there was a new coding changes for 2021 for physician practices. Those changes that took all of the complexity and decision making out of it and is only based on time is only for visits that happen in an office or clinic setting. The rest of the codes still continue to require these documentation, the multiple documentation requirements. Established codes, same thing. There's only 4 of them, but it's, you know, from 1 system to 8 or more systems, and from 15 minutes to 60 minutes, depending on how much time it takes to go through the visit and how many problems you're dealing with. There are also what's known as prolonged visit codes. They can still be used in community-based programs. They cannot be used in the office or clinic setting anymore. But you take those codes that were on the other slides and say you're using the code that's a 30-minute visit with 2 diagnosis codes, but you then spent more time with the patient for counseling or to do advanced care planning or whatever it was. But if you went over that time, but it wasn't directly focused on the assessment of the patient, then you would use these codes to get paid for the time you spent that was additional to the actual visit code. Again, depending on where the patient lives, there's different codes, and we do have a list of those codes. If anybody wants them, they can reach out to me. I'd be happy to send the list of codes for the different locations. Visits performed by licensed clinical social workers have their own procedure codes as well. So when they go in and do a visit, they would line up their diagnoses with DSM-5 diagnosis codes, and then based on how much time or the complexity of the visit. And there are multiple codes depending on what they're doing with the patient or with the family. And then you can also put on your claims any procedure codes, such as advanced care planning. If you're drawing blood to send to the labs, you're not doing the labs yourself, you can do venipuncture. If you do have point of service labs, you need to have a CLIA waiver. So that's one thing that you should know. But all of these procedure codes, I know one program that's going to be doing joint injections, those kind of things, those can all be added to the claim if you do them in the visit. And then I just put in a slide of an average reimbursement for Medicare. Again, remember, Medicare only pays 80%. The other 20% you collect either from the patient or if they have a secondary insurance. But these are just the home visits codes for palliative care and what an average reimbursement is for those codes. Managing expenses. Okay. So is there another?
No, I'll just chime in for a second here to give us some updates on some poll questions if people haven't been able to see. Circle back to what you were just talking about with the quality review of the EMN coding. 20% said that an employee coder does that quality review. 27% says an outsourced coder performs that. 11% was a quality RN, and 29% said they don't actually perform QA on those type of reviews. So 13% were others. So there's some feedback in regards to some polling on the last poll question. And just to circle back to with the challenges with the Part B billing, you can see from those estimated dollar amounts that Maureen just had on there is a lot of times that secondary insurance doesn't have a lot of reimbursement for that 20%. So you might be chasing down co-pays in the $15 to $20 range, validating patients' secondary insurance for it, to get that $15, $20 per visit, which, could be a heavy lift, but also could be the difference between if you're a profitable company or not a profitable company, chasing down that 20%. So just keep that in mind. And also, Maureen, just to circle back in regards to a question that came in, not to put you on the spot, but I'm gonna put you on the spot from a few slides ago. When you were talking about the 855B forms, one of the participants were asking, who typically fills that out and follows up with the intermediary in regards to those forms. And they're saying just the additional comment, which I felt that pain before, is that it is a very laborious exercise. So who do you typically find who has that information and put that together?
So that really depends on how large your company is. So some companies that are national companies that are starting palliative care, they have an administrative office-based or legal department that will fill out the forms. I have walked people through the forms, but I do not fill them out for people. There's a lot of like social security numbers and bank account numbers that I don't think everybody wants a stranger to have access to. So I walk them through step by step, line by line, what goes in each section. A lot of times they will send these forms back to me to review to make sure they're complete without the personal social security numbers and bank account numbers. But it is something that we have helped several clients with over the past few months now. In one company that I worked for, the executive director filled out the forms because there wasn't a huge administrative group of people to use. And in another company, I saw their quality nurse was filling out the forms. So it really depends on how big your company is and who can afford the time to fill out. Once you get all the information together, the 855B form, it doesn't take long to fill out. It's getting the wet signatures on the form that seems to be taking the longest amount of time. But it is tedious, and filling out all the forms is tedious. Typically, the providers fill out their own 855R forms or 855I forms. So I hope that answers the question. It really depends on your company and who you have available to do it.
I think what I also heard there is we feel your pain in regards to them.
We do. And I'll say that when I ran a family practice, I had to do the 855Bs and the 855Rs. Every time we hired a new doctor, the 855Rs had to be filled out. And then back then, when you revalidated with Medicare, you had to fill out the forms all over again. They were all on paper. There was no way to do it. If you do it through the PICO system, it's all online. You can save it and work on it, and it's a lot faster. But you have to then set up the PICO system for your company as well before you can get access to applying online. So I hope that helps answer that. I think there's a poll question about the teams, the palliative care teams. Am I correct?
Yeah, I think there it is right there. And it says, what is the actual makeup of your palliative care team? You have a licensed clinical social worker, an RN with an LC SW or an RN with an LCSW, with an SC, and also an aide as well. So this will be the last of the 4 poll questions.
Yep. Okay. So while that's going, the team types for costs for palliative care will depend on the type of visit team and location of the program that you use. So the types of teams, there are some that will use a nurse practitioner as the provider who goes out to see the patient, the licensed clinical social worker, and that's the team. And then there's a medical director providing oversight and an administrator who's making sure all of the quality metrics and everything, all the legalities are being taken care of on a day-to-day basis. And an intake person or scheduler or receptionist who can answer the phones, get all the information and demographics into the system, make sure all the consent forms are signed. Other people expand out their program and they'll add an RN to the team, and maybe the RN will process orders. They'll go out and do the intake of the patients. They'll do a eligibility, so to speak, assessment of the patient. Are they really appropriate for palliative care? Are they really needing hospice and they just needed somebody to talk to them about the difference? And then some palliative care programs are doing the full scale, a provider, the RN, the LCSW, the spiritual care or clergy, an aide, and then the medical director administrator. So you can think of it in lines of what services are we providing for our patients, and the more disciplines you have involved, the more return on the soft return on investment you get. However, you can only bill for a doctor, nurse practitioner, physician's assistant, and a licensed clinical social worker. You can only bill for the provider and the clinical social worker. So you have to always be looking at, what are your reimbursements going to be and your costs. And if you're just starting out, it's best to start out with just your nurse practitioner as your provider and a licensed clinical social worker. And usually that's a per diem or a very short part-time position until you establish your census. And then as you start growing and you're strategizing for the growth of your program, a marketer or a liaison who can go out and provide that education to your referral sources and expand your market for what exactly is the difference between palliative care and hospice. That will help with the growth of your system. But usually a startup palliative care program, the bandwidth financially for a marketer or for the full scale disciplines just isn't there. I also put average salaries that I found, and I use salary.com, and I use Ohio as the base for these salaries. So they may be higher or lower in your area depending on where you live. Medical directors, usually it's a contract and it's a stipend type of thing, and with specific tasks or hours that a program needs the medical director to spend. So it's hard to see, but the actual annual salaries for medical directors has been somewhere between $200,000 and $300,000 a year for a full-time medical director who just that's all they do is work with you. I don't see too many palliative care programs having a full-time medical director like that. Nurse practitioner salaries seem to average between $100,000 and $120,000 a year. Again, depends on where you live. And then these are the salaries for the others. So if you start looking at how you want your team to look, this is where your costs are primarily going to come from. Salaries are typically your biggest expense in any kind of business, but salaries, and then you also have to include benefits if you provide benefits for your full-time people, and in most states they're required to provide some kind of benefit. So those are things to take into consideration. Technology, electronic medical records. You're going to need a system that includes charting and practice management features. So the EHR piece and the practice management piece. Sometimes those are separate, sometimes it's all one system. The merit incentive payment system, this is the quality metrics monitoring. And I always tell people you should be monitoring for your quality metrics, whether you're in the MIPS program or not, because we don't know what CMS is going to do with that system and whether they're going to continue it. And once you have, currently the requirements are 200 Medicare beneficiaries or $90,000 a year in billing. Once you hit those, if they continue the program, you'll be required to provide quality metrics. So it makes sense to keep monitoring them until you know for sure you don't have to. Because the last thing you want to do is go through a year or two of providing care, not monitoring for the quality metrics. And then you find out you have to go back manually and research through all of your documentation and manually track your 6 or whatever metrics you choose. You want a pharmacy interface so that you can do e-prescribing through the system. You want an interface with the prescription monitoring program. I believe almost every state, if not all the states, now have a requirement for that for any narcotics. It needs Part B billing capabilities with a clearinghouse interface. E&M coding scrubbing capabilities is a nice thing to have. So as your provider is charting, it will recommend a code for the visit. You still want somebody to check that and make sure it's accurate, but you don't have to check it quite as often when it's done automatically, and it has to be set up correctly. And you also want a patient portal on your system, and that's for several reasons. It's unless you're strictly seeing elderly patients at the end of life and they don't know how to use the computer, palliative care is for early in the disease process. And a lot of those patients are already doing messaging to their providers, scheduling through a system, and paying their invoices. So to make it easy for the people who are computer literate, and it's getting to be more and more people, even my 85-year-old mother knows how to use a computer. So you want that availability for your patients to have. EMR costs, this is all over the chart. And I couldn't even find an average pricing for them. So it depends on the system, it depends on the software, it depends on how much hardware you need to get in order to use it. You always want to keep in mind the old saying, you get what you pay for, but you don't have to spend top dollar to have a program that works for you. I always recommend getting demos from several different programs and companies out there, because each one will have the same basics, but it depends on what other things you want and whether there's bells and whistles that don't cost extra or bells and whistles that do cost extra. What I am seeing is, although some of the software systems that do hospice and home health are trying to tweak their systems or make a palliative care piece to their system, only a small number of them actually are able to do the Part B billing, and only a small number of them have got the concept of a physician's practice as opposed to home health and hospice. So there are some out there that you can document, but your care plan is extensive and the Part B billing is okay, but it doesn't track your secondaries. And so you want to make sure that you have a system that's going to do everything you want it to do. And that might be different for different palliative care providers. So look at a bunch of them and then pick one. The practice management and EMR systems have been out there for decades. They've been in family practice and general practice for a long time. So there are a lot of systems out there that are really good, and the costs vary from really inexpensive to more money than I would ever want to spend on a computer. So take a look at them all and get pricing, and then make the decision that's best for your program. Other expenses to consider, supplies. Your providers are going to need the blood pressure cuffs, the sphygmomanometer, the stethoscope, the otoscope, a pulse oximeter, basic wound care supplies. So if they walk in to see a patient and there's a wound they want to take care of, they have the supplies, a pen light, and obviously there's more. Each provider has their own preferences in their doctor's bag. Time is also an expense. How much time are your providers traveling from one patient to the next? How much time is it taking them to complete their documentation and coordinate care? That's all expenses that you have to consider when you're looking at your budget. Some tips is to schedule patient visits strategically for routine visits, and decrease the travel time to homes, coordinate any of the visits that are in facilities. So if you have 4 patients in one facility or one complex of a continuing care retirement community, see those patients all on the same day for the follow-up visits. Limit the need to return for office supplies and meetings. Now that we know that technology and telephone calls and Zoom meetings and all these meetings work, try to limit the amount of time that you're spending on non-patient facing tasks. You can only get reimbursed for patient facing tasks. So you want to be with the patients, taking care of the patients, managing the patients. You don't want your nurse practitioners filling out forms and running to the office for supplies and having meetings that don't necessarily pertain to them. So be strategic on all of those things. And then these are some other expenses not everybody thinks about. Do you want a website? Are you paying for mobile phones for your staff? Any legal expenses? Do you have a retainer just in case? If not, are you having a lawyer look over your applications? Any consulting or contracting costs? Office space for your administrative piece. Business insurance, billing services. Are you doing your own billing? Are you paying for a company to do outsourced billing? Mileage for your providers, malpractice insurance for your providers. Are you covering that, or are they covering that? And any memberships to any associations or medical groups. The one I would strongly recommend for palliative care is the Center for Advancement of Palliative Care, or CAPC. They've been doing palliative care for a while now, and they have so many great resources and training programs that I personally do not work for CAPC, but I have seen several of the clients I'm working with get so much benefit out of their membership from CAPC. So that's one that I think is worth it for a program to join. Quality on palliative care. Why measure? You want to demonstrate your value to stakeholders. You want to manage your program's processes, outcomes, and expenses. And you want to monitor clinical and operational quality. What things to measure? Financial data, operational data, and clinical data. Those are the 3 areas for a business in practicing medicine, whether it's in a clinic setting or in a home setting. The National Coalition for Hospice and Palliative Care has come up with 8 domains to assess the quality of a palliative care program. If you look at least one thing from each of these sections, you have your quality program established. They do align with hospice a lot, but they're a little bit different in palliative care. This is the merit-based incentive payment system that we talked about earlier. It's quality performance measures your performance on clinical practices and outcomes. There are tools to help you assess healthcare processes and to ensure they align with your quality goals for healthcare. To meet these, there are 6 measures. You can either there are actually, I believe, 33 total measures from what I've seen, and you can pick 6, including at least 1 outcome measure or high priority measure. And the MIPS flyers and documentation online give you all this information. Or you can, if you have a subspecialty and you have a set of quality metrics in there, you can pick 6 from there. If they don't have 6, you have to do all of those quality measures. And again, it's advanced registration is required. This was the 5th year of the program with Medicare, and the last time I checked, I have not seen if they're expanding it to new programs yet, but I keep an eye on what they're doing with this program to see if it is something that we're going to need to get palliative care involved in your new programs. Successes, soft return on investment. An article in the New England Journal of Medicine showed that patients with metastatic non-small cell lung cancer had an average of 4 palliative care clinic visits. They showed significant improvements in their quality of life, decreased hospitalization, and decreased chemotherapy near the end of life with increased hospice enrollment, saving the Medicare system about almost $3,000 per patient. Improved transitions in care, again, earlier hospice enrollment, lower rate of CPR at the end of life when it's shown that CPR can cause more harm than good. A longer hospice stays with increased quality of life, a lower rate of ventilation in the end days, lower ICU admission rates, and better quality of life with improved caregiver outcomes. Financial success, managing expenses and costs is key. Controlling staff utilization with a priority to reimbursable positions. Ensure providers focus on patient-facing responsibilities. Office tasks like scheduling, answering phones, insurance verifications, and insurance prior authorizations should be completed by an office staff member. Bill the services appropriately and see enough patients. Bottom line, some programs have seen profit margins up to 10%. To avoid the losses, adhere strictly to your budget plans and scrutinize all your costs. Gaining access to patients early in the disease process is key to a successful program, and the satisfaction of the services is also critical, impacting your referral sources, patients, families, and your staff. So in the end, when you have a successful palliative care program, you have successful patients, physicians, families, staff members, and you have a program that can grow and really be a key resource for your community, and make sure that the patients don't fall through the cracks in their care. So now I can open it up we have about 10 minutes for questions.
Yeah, and this is Todd again. So one thing I did want to share with everyone was the results of the first poll question. Since you alluded to it at the end, is the profitability of a palliative care program. And of all the people on this webinar, none had a profitability of 10% or more. 8% were in the 0 to 9% profitability range. And I don't know why the light keeps turning off every time I do that. So every time I come on camera, the light turns off. But anyway, 8% of the participants had a 9% up from a 0 to 9% loss, and 18% of the participants had a 10% or more loss. And then 66% haven't started the program yet. So, the majority, if you look at, of the, 34% that have a program, 26% of them were, of that total, had a negative profit margin. So a lot of times that we say this is a loss leader for many organizations. And we also know, as you're looking to start this program, if you have questions that come up, feel free. I know to contact us. I know when we talked and did our webinar a few months ago, I think we got like 7 or 8 clients reach out or became clients that wanted to start a palliative care program. So maybe some of them are on the call today, but helping them out through the forms, helping them out of what to expect, a lot of stuff we talked about with this presentation today. We're more than happy to help you. It seems like the palliative care is definitely picking up steam. We're seeing a lot of investments across the industry from private equity groups looking to get into this space and other groups as well of just starting the program. But Maureen, to kind of turn it back to you, I do have one additional question that came in on the chat. And it said, do you have to have an RN on the team if you have a nurse practitioner? Going back to the staffing ratios or the program set up earlier in the presentation.
Okay, so no, you don't have to have an RN on your team. The basic palliative care team is a provider, so nurse practitioner, and an LCSW with a medical director. Some people prefer to have the RN to do that first like conversation with patients before the nurse practitioner goes out to do the initial visit, just to make sure they're appropriate for palliative care, if there are other resources they need, if it's a patient who's actively dying and they need more conversations around hospice, they send an RN out, but you do not have to have an RN on your team. Your nurse practitioner is a nurse and a provider. So most startups are starting with just the nurse practitioner, and then they have a per diem LCSW if there's any psychosocial issues that need to be addressed. And a lot of times those issues are more with family than the patient themselves. So, and I also wanted to say, for those of you that are seeing losses in your program, one thing that SimiTree has been doing for some of our clients is reviewing current palliative care programs and their documentation and their coding and their billing processes, and making sure they're actually capturing everything they have. And you want to make sure that your Part B billing obviously is in place first, because you can't bill it through Part A. So your hospice and home health enrollment in Medicare isn't going to help you. It is Part B, and you have to understand the Part B billing. But we have been looking at current programs, some that have been in business for a while that are not seeing profits, to see how we can help them change some of their strategies to be more successful and start seeing a profit. So it's something we are very interested in helping people with.
Yeah, that's a great point there, Maureen. And I'll add to that is, talking with many of our providers out there that might have a home health or might have a hospice already. And, a lot of times they have a palliative care program, or at least a form of a palliative care program, and aren't even set up yet, with the Medicare, provider. And they're almost providing they're providing these services for free, with the hope of having those benefits of a built-in referral source to hospice or home health, mostly hospice. So, you're already doing the work in those situations. You might as well fill out the paperwork, even though it might take a little time to do, and start that billing process off so you can get some money back to recoup the costs that are already going into the program. So just kind of keep that in mind. If you're one of those agencies that are already providing, this service in some degree, but not billing for it, you're really just missing out on a way to recoup the cost, in addition to having that built-in referral source for your hospice program. So,
are there any other questions?
That is it. I think you did a great job today, Maureen. I appreciate your time, and it seems like the 2 questions that came in we answered. If you didn't know, the handouts are in the top right corner above the chat. You can download the handouts, but if you have any problems getting the handouts, feel free to reach out to us. And thank you so much for, and I think they go to the next slide, Maureen. I think your contact information is there. Yep, there it is. That's Maureen, and then her contact information. As we transition to the new SimiTree, we still have our Blacktree email address, or the Simeon email address, but in the next couple of weeks, we'll be transitioning over to some new SimiTree emails, and be sure to share that contact information with everybody as we we talk with you. So thank you for joining us. And I think it may have been our inaugural SimiTree webinar to the industry. So this will go down in the record books there, Maureen, and the history books for SimiTree. Thank you for your time today. Like I said, I know you're very passionate about this, and I'm glad you're able to speak to the industry about it. And feel free, everyone on the call, or so thank you very much, and have a great day and great week. All right.
Thank you.
Bye.
Bye.